Thank you so much for having me. I'm so thrilled to be here. I always love being in Vancouver. And for those of you who don't know, I'm coming back to Canada in a year and a half, moving back to Vancouver Island, actually. So very excited about that. People are like, oh, you're not moving back to Winnipeg? I'm like, well, no, that's probably obvious. Love Winnipeg, but it's too cold. It's too cold. Love it. I love it. Anyway, so I'm really thrilled to be here, and I'm going to chat about menopause in the workplace. And this is the first slide, my introduction slide, just has a screenshot from Instagram. And I think social media is a really great place for us to kind of get a pulse, or take of the pulse of what's going on. And if you search hashtag menopause work, you see there's all kinds of posts coming up. So this is something that people are talking about. So it's so amazing that we're going to hear results from a study. It's so amazing that everybody here is engaged and interested in hearing about it, because this is really an important topic. So my goals today, my goals are to explore some of the unique impacts of menopause, to talk about some of the basics, because I'm a doctor and I talk to people about menopause every single day, but I appreciate that a lot of people don't know even some of the basics. And if we're going to have a conversation, we need to all be on the same page. We're going to discuss what we know about menopause in the workplace, which is sadly not that much, but we're going to know more after today, so that's amazing. And we're going to consider ways that we can empower women in menopause and empower those affected by it, and maybe figure out how we can take this to the workplace. So menopause in the workplace became important enough that this was actually became a white paper from the Menopause Society. And of course, when you look at all the sections, what you hear under every single read under every single section is, but we need more data, but we need more data, but we need more data. So again, super glad that that's the area that we're heading towards, but to just understand that this has reached an important enough level that our professional societies are taking notice of. So unfortunately, there is a lot of stigma, silence, and shame around menopause, which is really a big reflection, I think, of the impact of a patriarchal society on women and women's bodies. And the fact that this exists is really very tragic, that I hear from women who are from other generations, and we talk about what they felt and their grandmothers felt, and we even heard some of that in our introduction, that we have not yet moved the needle about having conversations about menopause. And so that needs to be changed. There's nothing shameful about talking about what's happening to your body. I mean, whether you talk about you're not having a period anymore, whether you're having a hot flash, or that you stubbed your toe, they should all be sort of as equally, non-exciting, if you will. Obviously exciting if it's happening to you, but it should all be on the same level of, it's either all a big deal or it's not a big deal. So why do so many women feel so uneducated about their bodies? Well, it's the umbrella of patriarchy. We have menstrual stigma. So we have to understand that we're trying to undo myths about menopause. These are related to myths also about menstruation. So this goes far back. We're not just undoing stuff that people learned a year ago or 2 years ago. We're undoing things that they've been exposed to since probably before they started menstruating, right? That we have sexual taboos that uniquely affect women. That we have a lack of interest in funding studies that we need to help medical conditions that uniquely affect women. And not that menopause is a medical condition, but it can cause lots of consequences. And that we have a dismissal of symptoms with women, and also a legacy of medical trauma. And medical trauma may be even much more significant for women of color, for women from indigenous communities, from women from underrepresented communities. So it's important to understand that legacy as well. And also, women are uniquely affected by ageism, right? I can't think of one man who didn't get a job, didn't get a role in Hollywood, didn't get anything because he had gray hair. Right? So I think that that's an elephant in the room that absolutely needs to be acknowledged, that ageism has a unique impact in our patriarchal society on women. Okay, so what to expect when you're not expecting a period? Nobody really talks about that, right? So, that's actually a really good, it's from my book, The Menopause Manifesto. I'm like, well, yeah, it's a really good quote. So we don't talk about it. We don't talk about it in schools, but you know what? In a lot of residency programs, training OB-GYNs, they don't talk about it. only 31% of residents in the United States had a menopause curriculum, which I find incredible in a really bad way. I trained in Canada, and we certainly learned a lot about menopause. So I'm not sure if it's a reflection of the time, a reflection of the institution I went to, or just a reflection of a difference in education in the US versus Canada. But less than a third of the trainees actually reported they'd been through a menopause clinic, which is astounding to me. Also, though, in the United States, residency is only 4 years, and it's 5 years here in Canada, so that, potentially that has an impact. But things that we know, so menopause, we have inadequate levels of menopause research. We know this. We also, though, know that menopause can uncover vulnerabilities that might be created by adverse childhood events, right? So being exposed to poverty as a child, being exposed to having a parent incarcerated as a child, being exposed to domestic violence as a child. All of these things can have a long-term legacy, and we can find some of those vulnerabilities being uncovered later in menopause. We also know that menopause is happening at the same time as we're aging. So what is menopause? What is age? We have to figure that out. And medically, it's complicated. Okay, so we're going to put a pin in the map. We're going to figure out how we're going to get started here. The first thing is we're going to talk just a little bit about menopause so we all are on the same page. And I like to think about the sort of the system that creates ovulation as being like the ultimate supply chain. And for those of you in business, I hope that that joke works for you. I ran it by my husband, who was was a CMO for many years, and he's like, "Oh, that's a good business-related joke." So think about it as the original supply chain. So the brain sends signals to the ovary to develop follicles. These are the units that eventually produce the egg. The follicles produce high levels of estrogen, and that estrogen travels through the body to get the body ready for pregnancy. It develops the lining of the uterus, causes breast changes, it causes all other kinds of changes to get ready for pregnancy. With ovulation, you release high levels of progesterone, which help also with the preparation. If pregnancy doesn't happen, eventually progesterone production stops, that hormone is withdrawn, and that is the trigger for menstruation. So that is the cycle around which reproductive health is built. Menopause is simply the end of that cycle. It's the end of ovulation. We often hear people say things that are inaccurate, like menopause is the ovaries dying or the ovaries giving up. And first of all, we shouldn't be using language of failure, right, to discuss the body. So I think that's really important. It's simply the end of ovulation, and it's the planned end of ovulation, because this has been an evolutionary mechanism that has been in place probably for tens of thousands of years. So what happens is we have a steady loss of follicles, these estrogen and egg producing units, throughout our life. When you're a 24-week fetus, you have 6 to 7 million, and by the time you go into menopause, you have about 1,000 left, and they're no longer capable of ovulating. So you simply can't produce the high levels of estrogen. Now, interestingly, all other cells in your bodies, or most of them, also produce low levels of estrogen. So your brain is producing estrogen, your muscle, your bone, but that doesn't spill into the bloodstream, because that estrogen's job isn't to get your body ready for pregnancy. That estrogen's job is just to look after that cell or that body, that part of the body. Surgical menopause produces a very different situation. We have an abrupt cessation. So instead of this decline of follicles, and obviously there are changes that go along the way that the body can adapt to, when people have their ovaries removed, they have a much more dramatic and abrupt switch. They often have far worse symptoms. And this is something to think about when people are considering leave, right, after a hysterectomy. If the ovaries are removed, there may be a more difficult time with a post-op recovery versus someone who's not having that. And when you think about the symptoms and ramifications, they can be worse for people who have a surgical menopause. So that's an important thing for us to think about. Now, the basics, menopause medically, when we talk about it, when we say menopause, we just mean the final day of the last period, and everything after is post-menopause. But that's kind of clunky medical language, and I think it's very fair to say that everything from the final period on is the menopause or the menopause experience. The time leading up to menopause is called the menopause transition, which you might have heard also spoken about as premenopause. And perimenopause is the menopause transition, plus that 1 year after the final period, because you can't say it was the final period until it was the final one. So you have kind of like the great period waiting for it to be the final period. So So it's all kind of very complicated and klutzy, and this is fine in medicine, because in medicine it's super important. You have to know exactly what you're talking about. But in the real world, when we're designing workplace policies, when we're talking to people about their symptoms, when we're providing medical care, it matters less. And there's really only a few very narrow medical situations where we need to know, are you actually after menopause or not? Now, the average age of menopause is 51, 52. The average age of onset of the menopause transition is 45. And, you know, I always tell people to think about puberty, right? So just like you didn't really know when you were in puberty until like you were really into it, that's kind of the same thing as the menopause transition, right? So you didn't really know you're in puberty until, oh my gosh, now you're actually really having a growth spurt. Oh, okay, there actually are some changes. It's the same kind of thing with the menopause transition. Now the thing is, just like the road to your first period, just like puberty, the menopause transition is chaotic. This isn't an orderly progression where the follicles start going down. This is a fits and starts. Sometimes you have, then again, your supply chain analogy comes in here. When your supply chain's not working, sometimes you have too much of one product, you don't have enough of another, and it goes back and forth, and you're like, oh my God, can't we get this system online? And this is exactly what's happening in the menopause transition. So symptoms can start here, which is important for people to know because there is a misperception that they only start after the final period. Bleeding irregularities are very common, and for a lot of people this can affect work performance. I'll give you my own example. I was once in an office talking with a patient, and all of a sudden, all over the chair. I had this massive heavy period, and I had to sort of navigate getting out of the room, and you know, it just, you know, you think about that and you think like, and of course I wasn't really embarrassed, but just didn't want to bleed all over everything. And you just think about those practicalities. Those are the kinds of things that can happen, and it's not that, it's not really very fun when it does. But this is a chaotic transition, and I think that's really important for people to understand that sometimes hormone levels can actually be higher, and sometimes the symptoms are related to high levels of hormones. Sometimes the symptoms are related to low, and sometimes they're related to the rapid drop. So what are some of the symptoms? Well, most people are familiar with the classic hot flashes and night sweats, but irregular or heavy periods, as I mentioned, brain fog, vaginal dryness, and pain with sex, sleep disturbances, joint pain can happen, and weight gain around the middle can also be a concern. And there's also medical ramifications, right? So depression can be triggered in the menopause transition, and this is something that is more common for people who have previously had depression. So important to know about if that's in your history. Loss of bone mass can lead to osteoporosis. Loss of muscle mass can be an issue, leading to sarcopenia. There's an increased risk of bladder infections, which can lead to a lot of missed work. And I think that we under-discuss the impact on bladder health because that has a significant impact for a lot of people. This is also a time of increasing risk for cardiovascular disease and increasing risk of risk factors for diabetes as well. And there's also this uncertain association with increasing risk of dementia. So when we think about all of this that's happening, I want you to think about how, you know, how we keep ourselves in balance, if you will. So we have all kinds of protective factors. We have our own neurobiology. You know, we have social support systems. Maybe we have exercise. We have all of these things that help keep us healthy. But then we have also these other things that can help tip us into not feeling well or having medical concerns, such as our neurobiology, such as hot flashes. If you're awake 5 times a night with hot flashes, or you're having them in the middle of a meeting, or these types of things might affect how you feel, right? And how you feel can affect how you cope with things. If you're having problems with mood or problems with depression, that can absolutely affect things. And if your sleep is disturbed, that can have a massive effect of things. So for many people, they're going along just fine, coping with everything, and then all of a sudden, it's kind of the straw that broke the camel's back, to sort of use a sort of a bit of a tired analogy, but it actually really works here. Sometimes it's just that one extra thing. And then there's something that we don't talk enough about, but the toll of emotional labor. So many, many women, and there's a lot of evidence also from workplaces that in workplaces, women do the bulk of the emotional labor at work. And this lifetime of emotional labor. And this is a clip I'm going to play because I couldn't have said this any better. And I saw this on social media recently, and I shared it on my Instagram. And the number of women who saw this and went, oh, that speaks to me, was pretty incredible. And obviously, Annette Bening is an incredible actress, so she's going to deliver the content far better than I could. But I just want people to kind of sit with this. This is a discussion about the emotional and physical labor of being a wife and a mother. But I feel this could be applied to people who are just doing a lifetime of emotional labor outside of a family situation. It could apply to so many people, so many women. Sort of this resonated with. That's pretty powerful. And when you think about it, you think that if you're born with a uterus, you've had to have this lifetime of menstruation, which may have caused you a lot of health problems. You've had maybe a lifetime of being dismissed by medical doctors or having medical research that can't answer things for you. You've had a lifetime of sucking it up. Maybe you had pregnancy and had complications. And now we know that pregnancy complications can also then have a massive impact on your health. You know that there's an old German saying that a pregnancy costs a woman a tooth each pregnancy, and there's actually data to support that. Right? There actually is. Somebody did a study that, that the health changes in pregnancy, the hormonal shifts, other things affect your dental health. So you have this lifetime of repercussions of having the system that's required to perpetuate the population, and yet you get treated like a second class. So I just think that when we start talking about the weight of everything, menopause is often happening at the same time where many women are kind of having a reckoning of all of the impacts sort of their lifetime of labor. So I just think that it's important to have that consideration. So what can happen at work, right? This is a place where many of us spend a lot of our times, and it's important for us to think about. Now, data is sparse. We're going to hear more. There are a few studies. Unfortunately, they have some methodological limitations. So what are the basics? We've heard some, I'm not going to go into detail about this, but in the United States, apparently it costs $1.8 billion a year, that 1 out of 10 people miss work. We have decreased productivity. These are important concerns. The symptoms that have the biggest impact on work are bleeding irregularities. You got to leave the office. If you're having a heavy flow, you got to go change your clothes. Hot flashes seem to be in studies to show to be one of the most significant impact. Sleep, mood disturbances, and as I mentioned, bladder infections. The amount of missed work for appointments for that, really, that can really add up. There are a lot of invisible, unequal burdens. So I just want you to think about the number of visits that it might require to go to get a bleeding problem sorted out, right? You may have difficulty accessing specialist care. Maybe you don't even have a primary care provider, so how do you even get referred to that specialist? I was on the ferry coming back from Vancouver Island last year, and this woman was obviously getting very upset talking on the phone because she was having a bleeding problem. She was trying to schedule a visit with a specialist. She'd waited 8 months to get this call, and there was one appointment that was offered. So she was going to have to cancel a whole day of work to go and do that because there was no choice. It was if she wanted to be seen soon, she had to take that appointment, right? So when we don't have enough access to healthcare, that has an impact. So there's tolls of seeing the specialist. So just if you have a bleeding problem, you've got to navigate getting through to your primary care provider. You may have to navigate missing work for that. You may have to reschedule things. You then have to navigate going to a specialist. Then maybe you have to take time off work to go for an ultrasound. Then maybe you have to take time off work to go for a biopsy from the lining of the uterus. Then you have to take time off to have the follow-up. And then maybe you might even need a procedure to fix that. That's multiple visits, multiple ways it impacts your life for one thing that's very common. 80% of women in the menopause transition have bleeding concerns. So when you start to think about what all of these conditions impact or how they impact your life, it's pretty significant, the amount of effort it takes just to get one problem addressed, right? And that's assuming that it gets fixed with that visit. Maybe you have to go back for more. Maybe there's more follow-up, right? So there's a lot that goes along with this. In one survey, so if you think about it, so then what happens? You're at work, how do you talk to people? How do you say, well, I need to go, I have bleeding problems? How do you make people comfortable? In one survey, only 30% or 31% of women felt comfortable talking about their menopause symptoms or experiences at work. That's not really very good. 1 in 6 supervisors said they felt uncomfortable setting up accommodations. I mean, menopause is not contagious. It's okay to talk about. I think we need to know that. It's okay to talk about. So what are some of the supportive workplace policies that we could think about? This comes up over and over again, environmental control. And I know it's not always possible because we build all these buildings with windows that can't open. But if somebody, and I said this at my work, if you can come by and give a heater to everybody who's in a room where it's cold, why can't you come by and bring a fan? I mean, Why couldn't we do both? Why couldn't we do both? If a heater's okay, a fan should be okay, right? In fact, I would think a fan is less risk from a fire hazard, but that's not my specialty. What about dress policies, right? If you have a very specific, tight dress code, you know what? That might not fit for somebody who's got a lot of hot flashes who wants to dress in layers. So these are things to think about. You know, are your dress policies uniquely affecting half of the population? What are your bathroom and break policies, right? If you have overactive bladder, if you have a bladder infection, if you've got to go change your menstrual products, do your policies account for that? What about flex time? I just talked about all of the things it takes just to get like one bleeding issue sorted out. How can that be accommodated? And what about having menstrual and incontinence products in the bathroom? Again, we don't talk enough about incontinence, which is a big issue. What about having these things available? So, you know, we think about if we could educate more people, then more people at work would know, but more people would also know then how to access good care, right? So when people also know that their work is interested, it makes them feel like they're being listened to. And I always think about the studies that just look at the impact of education on medical conditions. So, for example, there's a good study looking at educating women about a condition that causes pain with sex called vulvodynia. And when women go to a series of health education sessions on that topic, they're not getting medical care. They're not actually getting, meaning they're not getting prescribed a medication, they're not getting an injection, not getting a surgery, but just going and learning more about their health made them feel less anxious, made them feel better. And these are also important parts of health goals, right? So the more that you can educate people, the better they feel. And there isn't a reason why you couldn't have these types of educational offerings in a workplace. What could that education be? Well, it could be general education about menopause. It could just be teaching people about what happens, right? It could be about providing vetted resources, because it's very difficult to know who's a good place to go to, who isn't. So you could provide access to things that might help people along their journey, right? And you could teach people about the difference between quality care and not so quality care, so people don't get trapped, because you know what? There's a menopause gold rush right now. Wherever there are gaps in medicine, predators step in. And we're seeing that over and over again with things like hormone pellets and supplements and other types of things. And so these are things that can lead to a lot of health complications. And so it's important for people to be aware of them. And so what are some of the additional benefits that a workplace could offer, right? So CBT, cognitive behavioral therapy, is a fantastic treatment. It is the gold standard for insomnia. It works for hot flashes. It works for libido-related concerns. But people have a really difficult time accessing it, right? And especially CBT for sleep, it's a very time-limited, short course of treatment that's highly effective. Could a workplace offer that? Why not, right? Could a workplace offer, make sure that they have adequate medication coverage? I hear talks about, oh, well, we're going to make hormone therapy covered for everybody. That's great. What about the people who can't take hormone therapy? If you only offer one treatment, then you're excluding people. So you also have to offer non-hormonal therapies, right? So if you're going to offer medical coverage, you have to make sure it's equitable. What about physical therapy? It's very challenging for people to access, but it's one of the best treatments for many types of incontinence. Are these things that workplaces could think about? How could we fill in the gaps that our traditional healthcare system isn't filling in the gaps? And also, less than 10% of women in the menopause age are doing what we call the good foundations of health, meaning they're exercising the amount that we think we need to exercise, they're getting the right nutrition, and they're not smoking. And if that foundation doesn't exist, lots of other therapies aren't very effective. So could workplaces step in that area? Educational programs could teach health literacy. They could teach people about that the guidelines actually exist for a reason, and there's very good guidelines for people to follow. Help people be aware of the illusory truth effect, that repetition breeds accuracy. So be so mindful what you see on social media, because just because it's popular doesn't make sure that it's right. Understand the impact of data voids. When we don't talk about menopause, then we create this void and people come in to fill that void, and they're not necessarily the best of intentions. And also teaching people about bias, right? A person who's selling you supplements might not be the best person to get information on about healthcare, right? Because just like I probably wouldn't ask Merck to teach me about the HPV vaccine. It's a great vaccine, but I don't want to hear about it from Merck. I want to hear about it from somebody who doesn't sell the vaccine, right? So in summary, you know, women are vital for the economy. I don't need to tell anybody here this. that menopause can be challenging for some, it isn't for everybody, but that we have to respect, just like pregnancy, right? Some people sail through pregnancy and they have no problems, and other people have a very complicated pregnancy, and there's every permutation and combination in between. It coexists with aging, and we exist in a sexist society, so we have to be aware of that. That we need to make sure that the antidote to fear, to not knowing about what's happening to your body, that's quality information. People need to know there's options, and workplaces can help with this in so many ways. And women deserve to be valued during all phases of their life.